So good morning, thank you very much for your presence. I'm very, very happy on behalf of EPA to welcome you, so many people on our forum. Quite excited, we have a lot of people here in the room, so very nice, and also online. So looking forward to fascinating debates. We're a little bit late, so I'll cut short and we make some tempo. This is, by the way, our 10th forum, so it's a kind of an anniversary. We started 10 years ago, and I think it's been an excellent initiative started by Professor Gabel at that time, bringing people together, openly discussing relevant topics of mental health. So a little anniversary for us. I'm very proud to be in our EPA community as psychiatrist. I think we have a lively, big community, growing in many, many countries, doing many activities, so it really makes me proud and humble to belong to this young and growing community. I say growing, I think overall, with our 44 national psychiatric associations as a member, we represent about 78,000 psychiatrists in Europe, and latest data estimate the number of psychiatrists in Europe around 90 to 100,000. So basically, we represent about good 80% of all psychiatrists in Europe. And the latest data I have seen from Eurostat indicate that we're still a growing community. I know there are complaints, and true complaints, about workforce, but I think in many countries we see a little growth of psychiatrists. So I'm really proud and happy that we are at this time in a very fascinating and very vital profession, and an essential profession, I think. I'm also proud that we can organize this forum under the auspices of the Belgian presidency of the EU Council that is running by now, and I stole a little slide from them just to indicate where their priorities are for the Belgian government, and I think those are important priorities, and some of the topics they are working on are related with the topic of our symposium. A Europe that cares, with attention for health, workforce, very important, a Europe that prepares, and a Europe that protects. So I know that the Belgian government, with other partners, is working on developing a system how to do in solidarity between European countries on the aspect of medicine shortages, because that's something that we are confronted with every day. So I think we can be very honored and proud that we have this patronage and we can organize this under the auspices of the Belgian presidencies. As a Belgian, I'm privately proud also, but that's not relevant here. So we have a fascinating agenda. I will not go over this all, you have this in your agenda, but I think there are several important topics. First of all, we are going to focus on what are the barriers to inclusion in mental health, setting the scenes. Then dialogues on healthcare professionals and socio-economic aspects, very important. We have then an overview of our important ambassadors project run by Professor Rodzik. And then we conclude, I think, with going to solutions, at least trying to go to solutions the next step. So that is le petit menu for this morning. So I wish you a fascinating, and I hand over to Dr. Julian Beezhold, our Secretary General, and he will lead the further procedures in very good order. Thank you very much and enjoy the morning.
Thank you very much, Professor Dom. So welcome everyone. It's wonderful to see people in the room from literally all over the world, but we also have people live streaming on YouTube and live streaming on the Congress platform, so welcome to all of you too. We've got a great program, as you've heard. So I'm not going to talk for long because you want to hear the speakers. So we're going to start straight off with the first session, which is about what are the barriers to inclusion in mental health care, setting the scene. So our very first speaker, if you'd like to come up to stage, is Professor Guglielmo Schininà, who's the head of Mental Health Psychosocial Response and Intercultural Communication section at the International Organization for migration. So over to you.
Thank you so much. Can you hear me? Yes, so. No? I try again. Now, yes. I think I can also hear the echo. I'm very grateful personally, and IOM, the International Organization for Migration, which is the United Nations Migration Agency, is particularly happy to be at this table, because we are happy to be at any table where inclusion of migrants is obviously discussed, and that's what I'm going to present today. We have a long-standing collaboration with the World Psychiatrical Association that we signed when Dinesh Bugra, that many of you know, and is a pioneer in this field, was president of the association. So that's also why we feel obliged whenever one of the franchise organizations call us to be there. Migrant, I said, we are happy when migrant inclusion is discussed, but who is a migrant? For us, a migrant is anyone that moves from his or her habitual place of residence to another. This would be nice, and we can agree on this definition. It is a dictionary definition. However, in any country, the legal definition of a migrant is different from this, and depends on many issues that have to do with why a person left, refugee, migrant, which documents a person has, regular, irregular migrants, why they move, labor, other reasons, and what are the conditions upon their arrival. This obviously makes our job very complicated. You say that, okay, but for us as psychiatrists, how this translates? It translates in the fact that the same person that migrate for whatever reason might have different access to different care throughout their lifespan. This is something that affects your job, and we will see in how many ways. So migrants encompass, the definition of a migrant encompass a lot of categories, exchange students, international civil servants like me, every 5 years I move, the place where I live, academics, qualified managers, and so on, and vulnerable migrants, victims of trafficking, unaccompanied and separated children, irregular migrants, refugees, asylum seekers, internally displaced persons. Their proportion is, all migrants in the world are assumed to be 1 billion people. These include internal and international migrants. Vulnerable migrants, so the ones that are in the last categories, are probably 6% of this category, of this population. However, the discourse on migration is totally centered on vulnerable migration, especially in Europe, especially in the last year. Not only that, but also legal discourses dominate the identity of migrants, even though the terminology is often faulty. For instance, if you remember, the Syrian refugee crisis was called a refugee crisis because those were legitimately refugees. The Ukrainian crisis is called Ukrainian crisis. They are respected for their identity, national identity. Any other migrant that come from sub-Saharan Africa, for instance, from similar situations of war, is part of what is called a migrant crisis. I'm not considered a migrant, even though I'm Italian, I lived in Belgium till December, now I live in Switzerland, I'm not a migrant. I'm not a migrant for the European Union, at least since I was in Belgium, because the European Union doesn't consider migrants the one who migrate within the Union. But also because I'm rich. I'm rich. I'm not rich, but I'm like you. But I'm not poor, And so I'm called an expat, So and expats are not migrants anymore in the public discourse, So the term migrant is increasingly associated with stigmatized races and classes. Not all migrants are migrants, but certain categories of people are more migrants than others. And these are, in Europe especially, darker people from lower social classes. I know that social class is not a term particularly, in fashion, but that's it. So that's what it is. Also, as I said before, legal terms do not describe the individual experiences. If I'm a refugee, let's say I'm a migrant, an economic migrant in a certain country, and my own country entering wars, I can ask for asylum. If I'm a child, migrating by myself, I'm recognized de facto as a refugee. I have the same rights as a refugee when I arrive, but I lose them when I become 18. No, you know all these things if you are in touch with these categories. If I'm I'm a refugee that lose the status, I become an irregular migrant. Or if I'm an asylum seeker, that is not. All these people have different access to mental health care. So we have the same individual that is under my care for a period of time for depression. He becomes 18. I cannot treat him anymore. It has to go to a different system, if there is a system, because this is often not even the case. Not in Europe, not all countries grant access to universal health care to migrants, and we will see it in a second. Is it real that migration is linked with vulnerability and vulnerability to mental disorders? No, both parts coexist. And we know also that research is not particularly sound in our domain, because migrant categories are so many that it's very difficult to have a size or a result that fits it all. What we know is very inconclusive. Somewhere yes, somewhere no. PTSD, 80% in one population, 8% in another, so there is a problem with the syndrome itself. So we don't know really if experiences of migration make people more vulnerable to mental disorders or not. What we know is that certain experiences do. Trafficking in human beings, being tortured, being subject to sexual and gender-based violence, but these regard the migrant and the non-migrant populations at the same time, but those events are more likely to happen among migrant population because of systemic vulnerabilities that are present in the system. So the vulnerability of migrant also to mental disorder is a myth. This comes quite clearly out if we look at what Professor Cattaccini studied from the University of Geneva, that is how the perception of health and mental health of migrants changed across the centuries in Europe. And he said basically that we can divide an industrial and a post-industrial era. In the industrial era, basically migrants were considered healthier than the local population. In the perception, because they were workers, young men, coming to work, usually from the south of the countries, to the north. There were health checks at the border, and very often there were treaties between countries, Italy and Belgium, for instance, where the arrival of workforce was determined, and so on. Then there was the Berlin Wall fall, so the influx of people start to be undetermined, uncontrolled, we couldn't really look into it. So from the healthy migrant myth, we pass to the unhealthy migrant myths. They bring disorders, they bring diseases. And from the 90s on, the traumatized migrant myth emerges, in the unhealthy migrant myth. So we start considering, migrants more likely to be traumatized than other populations, something that is, again, not supported by research or our researchers, our data. So vulnerability is often not a precondition of migration, but a result of the conditions of migration. Irregularity that makes people basically, in many countries, even in Europe, unable to access mental health care, because mental health care is never at the primary health care level, or very rarely, It's second and tertiary. In the second and tertiary level, you need to register. If you don't have documents, you cannot register in most of the countries, or you are very reluctant to do it because you are afraid that this will bring to deportation. Dangerous travel, and obviously, if you are tortured, or you see people dying during the travel, you are more likely to develop a mental disorder. Being at the end of smugglers, any kind of objectification brings to more mental disorder. The criminalization of migration that brings to unlawful and protected detention of migrants. And we know from all researchers that administrative detention of migrants is a determinant of suicidality, depression, severe depression, and PTSD longitudinally over at least 5 years. Request of asylum is the only way of staying in the country. This makes the asylum status determination a very, very long process. All comparative studies that we have say that asylum seekers are doing worse than refugees and are doing worse than migrants, even irregular migrants, in terms of mental health. And when you go into qualitative analysis of why this is happening, it's because of the waiting, because they are suspended for many, many years, not able to organize their life, waiting for a determination. Stigmatization. Stigmatization brings to lack of access to mental health services, because there are legislation in certain countries, we are in Budapest, that prevent migrants to access certain levels of care, as I said before. But also there is misinformation from the provider side. So maybe the migrant magically, appear in a mental health center, and we see that there are obstacles to that as well, but then is turned off because the provider doesn't know that the person has the right, actually, to the care he is entitled, and so on and so forth. Then the discourse on migration. This is the discourse on migration, the dominant discourse on migration in Europe, these days. So stigmatization of mental health that exists in general, in our countries, and especially in a lot of the migrant community, united or linked to the stigmatization of migration in general, bring to a big reluctance, to people to demonstrate that they have a double vulnerability, which they are subject to double stigma.
1 minute.
Yes. So, what is our main understanding? First of all, don't reinforce the narrative of migrants being more vulnerable to mental disorder than others, but look at mental health of migrants and mental health care as a right that is in the Sustainable Development Goal Agenda 2030, a right that is in the Global Compact for Safe, Orderly and Regular Migration, in the new UNGA Resolution 2023 on mental health and psychosocial support. This is the first ever United Nations General Assembly resolution on mental health, was voted last June, that recognized the specific needs of migrants, displaced and refugee populations. Now, just jump, just 1 minute, and that will be it. So this is one of the first problems. Mental health care in all our countries is usually at the second and tertiary level of care. I already said it, not at the primary health care one. Migrants usually have access only to primary health care. The second one is that, as you probably know, there are 4 different health system models. Universalist, categorical, so where anyone has the same right to the same level and quality of care, or the ones where the category you belong to determine which kind of care you are. And then there are difference-oriented and difference-blinded systems. So we have to understand in which system we operate to understand better how we can include migrants. We cannot, let's say, promote the idea that all migrants should have universal access, to healthcare in a country where the access is categorical. What we should do in those countries is to create a category for migrants, even irregular migrants, as they do in Thailand, where they have an insurance premium also for mental health for irregular migrants, for instance, and things of the sort. Because otherwise you lose, you shoot yourself in the foot if you are advocating for migrants to have more than the local population. And then with WHO, we share the same 5 golden rules, principles for migrant inclusion to mental health care. The first, I already said, is grant to all migrants access to primary, secondary, and tertiary health care, not only primary. Mainstream mental health in primary health care, because that's where most migrants are. The second one is that mental health and mobility considerations should be mainstreamed in all the concerned systems, not only the health one. Educational, social care, healthcare. Yesterday I was with a young guy, a 21 years old student here in Budapest that come from Rafah in Gaza. I asked him, did anyone from the university contacted you, asked you if you needed anything, to talk? No, no one did it, so that's where we have to be, at the front line. The third principle is that we don't have to create parallel systems for migrants that usually tend to be trauma-informed systems, even when trauma is not the issue, but other are the issues. But we need to have existing services that are potentiated in order to be able to respond to migrant populations, because migration is an issue of today's anthropology. It's not an emergency anymore. The fourth principle is that we need to have services that are linguistically and culturally appropriate and efficacious. Cultural diversity is not a joke, it's not just translating terms, it's really working between paradigms, and this is something that we have to know. The baseline is at least having translators. But having translators means also that we have to be trained to work with translators, because we are not. We are trained to work one-to-one, not with a third person in between, and also avoiding the stigmatization, the cultural stigmatization that translators can bring. Because obviously, not everyone that comes from a culture share the same set of values, so we have also to put the person at the center, not to stigmatize them because they come from a certain culture based on what the translator thinks is what the person thinks. This is everything from my side. Thank you very much.
Thank you very much. So we'll move swiftly on. And just to remind everyone, there is an opportunity for questions from the audience right at the end of the forum. So the last session will be questions and answers where you can all participate. So the next speaker is Kjell Larsson, who is from the European Federation of National Organizations of People Working with the Homeless.
Order.
We're deliberately pausing to create this anticipation.
Thank you very much. And thank you very much for inviting me here too. My name is Kjell Larsson and I'm the president of FEANTSA currently. I don't know if you know anything about FEANTSA, but it's the Federation of National Organizations working with homelessness. And I'm also going to touch upon some issues that my former colleague talked about also. Migrants can also be classified as homeless and the results of that. Usually I'm every day working as a developing director for a national NGO in Sweden called the Swedish Association of City Missions. But today I'm going to talk about homelessness and mental health. Let me see. Yeah. What we know about homelessness and how people are, accessing to mental health care. International studies conducted during the last 20 years, they have found lifetime prevalence rates for mental health problems for between 60 and 90% of people experience homelessness. That's a much higher frequency, of course, compared to the general population. And in Germany, for example, the data shows that homeless people are affected by mental problems is somewhere about 4 times higher rate than the general population. I'm just going to give you some examples from different countries here. And a recent report also from Spain that also shows a very close relationship between homelessness and mental health. This is not, like brain surgery, actually. Everyone knows that when you are homeless, you are in a very, fragile condition. And FASIAM shown that to be a risk at the mental health is like 70% of all the people that they were interviewing. So it's a real trauma of not having a safe house or a safe place to stay or a safe place to live. So that's one of the most important things to remember also when talking about homelessness, but because, and maybe mental health also, because before you can do anything, actually do anything, according to mental health or addiction or whatever, you have to have a safe house, because it has a huge impact of people's mental well-being. And of course, it can also be a trigger for addiction and have significant impact on individuals' overall health status, of course. That is what we know. I don't have so many slides as you had, so don't worry. I'm going to keep it quite short. So the barriers are often similar for socially excluded people, and of course for people facing homelessness, it's even worse. Homeless people are deeply marginalized, which often denies them access to information in regard to their health entitlements in general when it comes to primary care, leading to exclusion from mental health care. It's the same, process as for migrants there also. Stigma and discrimination, and well, we heard a lot about that too. often associated with homelessness and people's living situation also, and mental health issues. And if you have previous experience of stigmatization and discrimination, that could cause people to avoid seeking mental health care due to fear of these judgmental perceptions also. So it's kind of a negative spiral there. So homeless individuals may have difficulty accessing mental health services due to, like simple things like lack of transportation, like financial resources, and additionally, it could be long waiting times, it's limited appointment, and a homeless person, well, it doesn't have, like a calendar with all the appointments written down. It doesn't really exist for a person like that. So it's quite difficult sometimes to make these appointments and hold them also and be there. And the whole feeling with housing insecurity or instability is that it creates also barriers to a lot of things, and some individuals may prioritize other things also, other basic needs over seeking this mental health care. And that leads to a cycle of unmet needs and worsening their mental health. So it's, like down-going spiral. I must say something also about the healthcare system, complexity, and how to navigate it. I hope I don't step on anyone's toes here, but I know for sure that the healthcare system can be challenging for all of us also to get inside. I know for sure that it is so in Sweden. I can only talk for myself. And for homeless individuals, particularly if they have a co-occurring mental lack of physical health conditions. Well, this could also be a lack of coordination between service providers, and of course there are specific challenges as ethnicity, age, or gender, LGBT, and or restrictions determined by migration status, as we heard before here. But not everything is completely dark. I have to mention also something about the possibilities, of course, because I really like this evidence-based model called Housing First, because that is really a very good program that's designed to end homelessness for people with mental health issues or addictions issues or whatever. They live on the street. And the approach is with these multidisciplinary teams as assertive community treatment, these ACT teams. I think you all know what I'm talking about. It's well-documented community mental health program for treating those with severe mental illness. I think you all heard about this. And these multidisciplinary teams delivers a full range of medical and psychosocial rehabilitative services to clients in a community rather than in an institutional setting also. And that could also be some good way of handling these things. And we have seen a lot of good experience in doing that. I have a quote here from Leonard Steen, who is a co-founder of this ACT model. Here you can read it yourself. And actually, I've heard this. I've been talking about Housing First for 15 years now, and it's still kind of an innovative way of approaching homelessness. And they have, and usually people say that, well, even if people get housed, you don't gonna get more. You're not gonna be. Your mental health is not gonna be, go away, or your addiction problem is gonna go away. But but still it's quite an interesting study made by the World Health Organization that called the Health Equity Status Report. It was made in 2019. Thank you. And that said that living condition like a safe and secure house contributes to inequities in self-reported health. It was 3 times higher than health service contribution. And that was a very interesting thing to hear because, you know, like having a safe and secure house would make you, you know, like everyone has said, no, it doesn't make you feel better, but it does. It really does improve your general health if asking people. And this study was made by, I don't know, it was a huge study that was made in 2019. So it's very interesting reading if someone wants to read it. So my conclusion for people in homeless situation with mental health problems or whatever is that the best results is to make sure that people, when they are in homeless situations, as soon as possible, get a safe and secure house, and then if needed, start motivating to treatment, well, in community rather than institutional, I would say, but depends on what works and what's not working at the time, and without losing the safe and secure house. So I don't have any more to say about this, but if you want to know more, you can look up in FEANTSA or in the Housing First Europe Hub or in the FEANTSA research. It's about housing first a lot, of course, but it's more like what works for people in homelessness. Thank you very much, and I hope I kept the time.
So thank you very much, Kjell, Larsson. So we've now had a perspective from the point of view of migration and homelessness. So we move on to our next 2 speakers. André? So we have a joint presentation from the President of GAMIAN-Europe, who is Péter Kéri, standing next to me. This is the Global Alliance of Mental Illness Advocacy Networks, and the Vice President of EUFAMI, who is André Decraene. EUFAMI is the European Federation of Associations of Families of People with Mental Illness. So in other words, we now move to a perspective from patients and from families and carers. Over to you.
Very, very good morning for everyone. And it is my pleasure to see so many familiar faces. And I'm very glad that so many of you we met before, and I know the smiles around. It's a pleasure for all the patients throughout Europe. And let me give a couple of Hungarian words. Nagyon szépen köszönöm, hogy Magyarországról is megtiszteltek minket a látogatásukkal, és remélem, hogy találkozunk még. So my name is Péter Kéri, President of GAMIAN-Europe, since 1.5 years. Board member of European Psychiatric Association. What is something novel? What is something pioneer? A patient in the board of European Psychiatric Association. I'm a board member of European Brain Council. What is something novel? We can be there to shape the future of our brains or of our research around us. And I think it is something very fantastic. So what I can say, we face a brilliant future if we work together. But how it will be done? Oh, I have a slide change somewhere. What I see since I'm president of GAMIAN-Europe, and we represent approximately 60 member organizations, nearly all the patients throughout pan-Europe, international organizational level cooperation is missing throughout Europe. So there are plenty of patient organizations in here, in there, but they do not know anything about each other. Without this cooperation, patients will be silent. We will not know what patients really will want in the future and what happened in the past. Today, what we see from GAMIAN-Europe, that patients are not transparently informed about their illnesses, about their possibilities, about the outcomes of their illness throughout Europe. It is not equal in many, many countries until we do not have a common ground about it, and until patients cannot be sure that they receive the same treatment and the same care every country, then patient will have worse positions. And if I call another country, a fellow patient, he will say that, oh my God, my bipolar is better there in my country. How can it be possible that in your country it is worse? I can talk about it because I was diagnosed with schizophrenia when I was 43. It is called late onset, and before I had a life. So now I have a chance to compare what is being normal and what is being mad today. We are talking many times about stigma, but where stigma lives first? Stigma lives first, I think, in ourselves. Facing that from today I'm considered mad. It is something bad, it is something awful, horrible, but you can just have in your side. But after that, you see that in professional souls, there is stigma. Psychologists, psychiatrists, professional carers, decision makers, they have stigmatizing attitudes sometimes. They know it sometimes. They say it sometimes. They're very open. Yes, Peter, we are stigmatizing until we are not honest about what stigma lives in our heart. Until that time, people will not be healed in the way they should be. I'm very proud that since my presidency, I was able to pray and to connect different disciplines throughout Europe. Psychologists, psychiatrists, political decision makers, lawyers, patient family organizations. We are working close together to achieve a better future. Sometimes you think we are on the same page. No, we are not on the same page. The illness is mine. You are the decision maker. You are my family member. Everybody has their own role, but we must agree how we cooperate together for a better outcome. And I think it is the future too. Many times we are talking about illnesses, conditions, but these are not really as defined as patients would deserve it. Are those definitions are coming from patients as well? Am I sick? Am I really sick? If I have a skin problem, certainly it can be diagnosed easily because evidence-based, there is a code for that. But what if I think about something, about a pineapple in a shop and it is in my head? Am I schizophrenic? If I think something malicious about that pineapple, am I schizophrenic? Who will diagnose that? Will it come from patient's perspective as well in the future? Who is sick? Who is not? Who is ill? What is sickness in mental health? And I think in future this definition should be clearer, nicer, and patient-centered. Mental health care system, we have around, but many, many times patients are the only active members who can have a real view about the care system around them. And they are transparent about talking what kind of mental health system I live in, what kind of treatment I receive, how do they behave with me, and they want to talk about that. They are nice, they are kind, they want to improve the system. They are friends like carers are friends of the patients too. And if we cooperate in a friendly, normal, beautiful for me manner, then a nicer outcome we will achieve. And involvement of patients in this progress, I think it is critical today. And I'm very glad that I'm receiving invitations from many organizations, and thank you very much for that. Precision psychiatry is one road what I like a lot, but I usually do not call it precision psychiatry. I call it precision care, because what I see and patients see in the future, if we know the past, if we know the present, and if we know the outcomes of a patient, including the body health, including the psychosocial past, including the body past of that person, we can understand the mental health situation of a person globally, and we can have better outcomes. So for me, precision psychiatry means precision care in the future, including everything biomedical, psychosocial, and understanding historical things from the patient and families, and I think it will be the future. And till I'm president of GAMIAN-Europe, you can count on an organization what will help you to achieve these goals. Thank you very much. Be with us.
Thank you very much, Peter. Can you hear me? Okay, I think this is all right. I'm André Decraene. I'm the Vice President of EUFAMI, which is the organization... If you want to change time. Sorry.
This one is yours?
Yes, that's it. Thank you very much. Okay, I'm representing the families. EUFAMI is the organization, a European organization that represents the families of persons with a serious mental health issue. We call these families sometimes family carers or informal carers. So I wish to thank President Dom and the program committee for giving us an opportunity to give our perspective. However, the subject is too vast to be treated in 5 minutes that were allocated to us, so my intervention will be limited to essential findings, and I will end by highlighting the essential conclusions of a very recent general population study performed in Switzerland during the month of November of last year. Okay. Very good. My hope is that this will foster enough appetite for further exploratory research into the lack of pertinence and adequacy of present-day mental health services as far as family and caring families are concerned. Our starting point and fundamental belief is that it is possible for all patients to achieve control of their life, to recover their self-esteem, and move towards building a life where they experience a sense of belonging and participation. This is an essential component of the so-called recovery approach. I wish to give you one example. My son is now 45. He's been in psychiatry for more than 20 years, and I have seen a very, very good development of the care that was given 20 years ago and present day. Inclusion and participation is an essential component of the recovery approach. My son is now writing poems and drawing, doing some artwork and playing fantastically music. He was very gifted. But what happened with him when he was 20 or 22 was a terrible thing. It was like a disaster, a complete collapse. But with the present day help and attitude of professionals and the help of parental care, you can give them a fantastic life, a self-fulfilling life where they recover self-esteem. And if you allow me, Peter, I think I cite you as an example. You have a self-fulfilling life where you have recovered your self-esteem. So I want to give this as a message of hope. But one of the prerequisites for that is participation of the patient and of his family. Families are an essential component of recovery. Families that are left aside for one reason or another can be counterproductive. Instead, informed and collaborating families can be a huge accelerator of recovery and avoid relapse. The relationship between patient, professional carers, and informal carers, sometimes designated by triade, is a win-win relationship. Everything must be done to give necessary and useful support to families caring for patients. And this is not the case yet. So EUFAMI's standpoint is that families must be informed and involved at every stage of the therapy, including diagnosis. That is what is called the therapeutic alliance. Furthermore, families have to be cared of as well, because their situation is very stressful. They need attention, and the need is very important, as is demonstrated by a recent population study effected in Switzerland in the course of November. The study was effected into the adult population of the French and German-speaking parts of the country. There's about 8 million. And the adult population is about 6 million. So the important findings are as follows. 60% of the general population, and that is very important, 60% has had or has experience of taking care of a person with mental health issues, once in their life at least. Half of them, which is about 30% of the population, is now taking care of a patient. This is about 2 million people actually taking care of a person. That is extremely important for the general well-being of an entire society. This number is huge and is a revelation. About 1/3 of them, which is about 600,000 people, express a strong need for support, which they do not find. 75%, or 450,000 people, are members of a close family of a person suffering from mental health issues. These need special psychological support to overcome anxiety and do feel not enough supported. They express the unfulfilled need for peer support and information about the situation and how to cope with it. The study, thank you, the Swiss study clearly demonstrates that families do not receive the necessary support and information and are therefore often lacking the means to help patients recover. I think that Switzerland is not an exception in our European countries, and that the conclusions of this study can be easily transferred to other countries. That is what I wanted to say. Thank you.
So a huge thank you to André Decraene, Vice President of EUFAMI, and to Péter Kéri, President of GAMIAN-Europe, for their perspectives. We'll now move straight on to session 2. So could I ask the panel members to make their way up onto the stage, please? So this is a roundtable discussion, because we've now heard from the perspectives of migration, homelessness, patients, and families. So we're now going to have health professionals. So we welcome to the stage, I'm not going to announce them in any particular order, but Elena Moro, who's the President-elect of the European Academy of Neurology, John Francis Leader, who's a board member of the European Federation of Psychologists Associations, Nina Kilku, who's president of Horatio, which is the European Psychiatric Nursing Organization, and our very own Andrea Firillo, who's the president-elect of the European Psychiatric Association. So thank you for joining me on stage. So this is now an opportunity for a little bit of discussion between the clinicians from the very different professions on the stage. And we've got a number of questions which we sent you in advance. I hope you've all had a look at them. And I'm going to start with the first question, which is, what are the main challenges that your discipline or area of work is encountering at the moment? So,
should we start with the neurologist?
we have a volunteer.
We are cousins in the disciplines. I think, thank you very much for inviting a neurologist to represent the challenges that we have in Europe. Let's talk about Europe. And I think we are very similar to what has been already depicted, that there is an increase of neurological disorder burden in Europe and the global level. I think the last Lancet reported that 45% of the population in the world has a neurological disorder. But we are not 100,000 neurologists, psychiatrists in Europe. We are 45,000 neurologists. So we feel a bit lost in taking care of our patients, the patients living with neurological disorders. So this is a challenge, right? So the burden of neurological disorders is increasing, and we are not so many in taking care of patients with neurological disorder. And most of these neurological disorders are stroke, migraine, epilepsy, Alzheimer. And we share some, especially some psychiatry, they help us in taking care of dementia. So this is a major challenge. And then I think a lack of resources. We always say the same thing, but the healthcare system are not really prepared, right, to this increased number of aging people, because we know that age is a risk of neurodegenerative disorder and stroke. So we are facing all these issues, and we're trying to get ready, especially with the new neurologists, to take care of that. And I think we will discuss later, we are moving towards prevention, right? So I think you too, but especially talking about stroke and dementia, we know that now we can do something in prevention, and I think this is where we have to go.
Yeah, thank you. So Nina, maybe?
Thank you. First of all, thank you for the invitation. So I'm presenting European psychiatric nurses, and the terminology is a little bit confusing because it's actually psychiatric and mental health nursing today. So we are representing 20 countries in Europe, and there are always space for more if someone wants to join us. Nurses are the biggest professional group in healthcare, also in mental health settings. And when we are talking about mental health nursing and psychiatric nursing, it also expands to promotion and prevention, not only in the care services. And we all know that there is still a need in many countries to have more emphasis on community-based services, and also in primary health care on mental health issues. So there is a big field also for nurses who have been specialized in mental health or psychiatric nursing to work in different settings, both with the patients, clients, families, and communities. And I really thank the previous presenters today, because I think you were very beautifully kind of providing the landscape where we are working. There are a lot of things, social determinants that we need to think of totally new way, probably also in different professions, and also the role of the families and people with lived experience. So there is a big task to do, and the biggest challenge at the moment is the shortage of nurses also in the mental health area. So we really struggle in many countries to have enough people actually already in the services which we have at the moment, and not to talk about the expanding of the services also in the new fields, like also in NGOs. And this is something that I think we can probably all share, that we should do something maybe together to make the mental health field or psychiatric field more attractive also for new people to enter the field, and also to keep them who are there. So we need to also take very good care of the people and our professionals who are working in the field at the moment. And unfortunately, in some of the studies, the mental health nurses are actually giving quite sad examples how they feel that they are treated. It's not only the salaries or poor management, but also kind of between the professionals. So I think we need to think about a little bit when we are talking about humanity in mental health, that it also expands to the professionals in the field, if I may be a little bit critical in my first talk. But I hand over to John.
Thank you. Please, John, from a psychology perspective.
Well, thank you very much to my EPA colleagues for having me here on behalf of EFPA, the European Federation of Psychologists Associations. And I think the title does a very good job of answering the question, which is that word inclusion. And I really liked that when I saw it. It was a very, very good way of pitching today, I think. And I think it points to the center of the challenge really for all of us, as you were just mentioning, is how do we draw together so many different things that are happening within individual professions, between professions, and of course keeping patients, clients, service users really at the very center of that. It's a challenging thing, but it's a very exciting time. And I think one important essential point is that inclusion, being inclusive, is and needs to be a verb. We're doing it right now. It's an action. We're figuring it out. We're sitting together, and if we can keep that up, that's good. I think three themes stand out within psychology, but I think mental health more broadly that are probably relevant right now. One is, I suppose, what you would call the traditional professional challenges, training, inclusion in who's getting into training, accessibility around it, standards, professional mobility. These kinds of topics are as relevant as they ever have been. So those kind of more traditional challenges continue to be very, very important to stay aware of. Two maybe slightly newer or more current additions to that. One is, I think, the expanded scope of mental health, which is something we're all becoming increasingly aware of. Now, it was always the case, as I like to say with clients when I work with them, sometimes you're not depressed, it's just that your life is depressing. And, you know, we've heard some very good presentations already this morning on that. If you're homeless and you don't have a house, well, you know, that might need to be part of the process. We can't forget these important factors. So, the European Commission's comprehensive approach to mental health last year, already mentioned today, the UN work on the mental health and psychosocial support resolution. We've seen some very big moves to really take context into account. And it doesn't take away from all the other good work we've already been doing in a more traditional clinical sense. That's all good stuff. But it really expands upon it. It puts scaffolding in place to be able to get much more effect from those other kinds of supports. So I think that's a huge topic area. And the third thing I might mention then, so the more traditional approaches, the expanding definitions and scope of mental health and inclusion of context. But the third thing is digitalization, which I think is something we're focusing on hugely. So the role of artificial intelligence in augmenting and supporting treatment and diagnosis and potentially in prevention in other areas too is something that we're looking at closely, and I know we all are in different ways. And it also potentially has a huge impact on professional mobility as well, cross-jurisdictional practice and people in different locations. So I think these are some of the topics that it's really interesting for us to all be able to share and discuss together, because we don't have the luxury of being in silos, I don't think, anymore. If we ever had that luxury, we were chatting beforehand that this conversation we're having right now about how all of this comes together, this is something that many people themselves are trying to figure out on Google when they're experiencing distress. Who do I go to? What are the terms? What's it called? So I think it's very healthy that we're at least trying to do our part.
Thank you for that, Andrea.
Yes. Good morning, everyone. Thank you for coming. Thank you, Julian, for chairing this session. Let's come back to your initial question. You say, what are the challenges? In mental health, we know that we have several challenges we are facing. We know that mental disorders, the prevalence of mental disorders is increasing worldwide. The burden from mental disorders as from neurological disorders is increasing. We know that we are working very hard to reduce the burden, to improve care, but of course still there is something to do now. I would say that the problem starts from the way we make the diagnosis of mental disorders. We know that there are hundreds or thousands of ways that we can make a diagnosis of, let's say, major depression. They are different disorders and they have to be treated differently. As also Peter was saying before, personalized psychiatry is something possible, but we need a personalized care approach to mental disorders. And in order to do so, we need also a better collaboration and a better relationship with the other health professionals and allied professionals. And this is why one of the motto of this Congress, open and inclusive toward patients, toward family, toward carers, toward other allied professionals. We also have another, I think, a big problem, that is that of stigma. Stigma is among patients themselves, among professionals, but it's also among the general society. So we need to send clear messages to the general population and to all other people involved in the healthcare settings, because it is really important that someone who suffers from a mental disorder cannot have the same problem as they had in the past. One last point, I just wanted to tell you that mental health care for years has been mainly reactive and palliative. We have been isolated from the rest of medicine and from the other professionals for too long. I think that it's now time to stop it from now and from this meeting.
Thank you. Thank you very much. So it's a great start picking up that last point, and as made by, I think, all of the other speakers, to have all of us together on stage, and including the speakers earlier on. So I want to move to next question, really, which is thinking about the workforce in your particular professional field. What do you think the biggest challenge is at the moment?
You're looking at me. Well, as I said before, we feel a bit lost, right? Because the manpower, women power is reducing. And especially among the young generation, this burnout, right? The sensation to not be able to do more, and the desire to reduce the time of working, which can be very good. But it means that there are less people involved in the care of our patients, right? So we don't have the solution for that. I think we have to work together. We are very expert in burnout, but this is a very important challenge for the young generation and for the oldest generation to manage, and is one big challenge. And then the lack of interest of healthcare professions. So very few people that are interested to become nurses, to become physicians. We might understand why. Maybe the salary is not so attractive. There are other interests that are coming. The new generation are different. So there is a diversity, right, to consider. But there is an impact in taking care of our patients and in developing the disciplines. So maybe artificial intelligence will help, we will see. And then the lack of funds. We have free wars in Europe, and this is a big impact for having funds and money to improve our healthcare system. And as you said, it was said, disparities in the countries. We are in Europe, but we are so many different in taking care of our patients. And these are challenges that are, at least I think in neurology, but also in psychiatry and other disciplines, we see impacting our profession.
Thank you, Lena. And Nina, from a psychiatric nursing point of view, what are the challenges
Thank
of the
you.
workforce?
I was already referring to the shortage of staff and the issues of sustainability and retention. So those are big issues, and also at the same time I can underline the same issues that Elena was mentioning, but also we hear more and more like moral distress, ethical dilemmas, because when people are thinking and the nurses are thinking, I'm not able to provide the care the way I would like to, I am not able to provide the best care, because there are so many patients coming in and out of different services. I can't stop, I don't have enough time, and all these kind of resource things, they are really affecting also to the attractiveness of the profession and the feeling if I'm doing a good job or not. And of course that's also part of the job satisfaction. And we all know that it's highly important when we are thinking our daily practices, if we are thinking that we are doing important work the way that we would like to do. So I think there are a lot of kind of structural issues, but also these kind of issues that we need to think about the content of the work in a different way. And I think there are problems also when we are thinking about the artificial intelligence and the digital things. So it's a big change and big transformation of services, and it's a big educational challenge at the same time, but that's really needed, I think, also. So I know that in some countries there has started to have a bigger intakes of the students in different training programs for these reasons, but the problem is also that the students are ending their studies prematurely, so that might not be the biggest kind of solution to this problem. So I think we need to look at that in the different levels, and also to engage more and more people working in the practice to discuss about these things. What should be done differently so that you feel okay to work here, you want to come here, and you would also like that your family members are getting good care, or you actually want to invite also your friends to work in this profession. So this kind of positive message is a little bit missing at the moment from the mental health field. So I think it's very, very important that we also trying to make it more attractive to the younger generations with positive examples.
Thank you.
This is good. It feels like group therapy. Because I'm hearing the same thing, but from a different perspective, so it feels validating. I think. So I think I think everything that's said is very valid, and I really echo it. I think there's a kind of a lifespan approach we need to take almost to a mental health practitioner's career, isn't it? From the very beginning through the career, and as it develops, making sure that that inclusivity is really accounted for in terms of who is actually coming on board. And the various barriers and challenges, including socioeconomic ones, to actually just getting into that system to begin with are very, very important. We can only do so much in the later stages if we actually have the people to begin with in the earlier stages. So it's something that's really important. Burnout and well-being, I mean, really practicing what we preach remains something that is extremely important. I think maybe something to particularly pick up on is the maybe the existential factors at the moment that are affecting a lot of people, and I think again this comes into those 2 points I mentioned previously. One is extending the scope of mental health, and the other one is the digitalization side of things. These are, I think, very good things potentially, but also very challenging things in the short term, as we already have a lot going on and maybe busy schedules, and then we try and incorporate all those other factors as well and learn, and also make kind of ethical judgments about the future in the midst of busy practice. There's an awful lot going on, so that goes back to the burnout point. We've got to be careful with that, but it is something we need to give attention to. So if we're thinking about an extended approach to psychological well-being, I mean, architecture can start to come into that, and talked about housing earlier and all kinds of things. So there's just really interesting questions about what our careers are going to look like 100 years from now, where those boundaries are going to be. And it's not, of course, that our great specialisms won't still exist. They will, hopefully even more so than ever before, but there will be much better webs or networks between them so people can go to the right place at the right time, and we can kind of get on with the stuff that we're good at, and other people can do their part too. And certainly with digitalization, that's going to be a big part of it. One of the things I work on is working with phobias, and particularly the fear of flying. So we have a flight simulator, and we help people with that. And you know, that metaphor the airline pilot always uses is, okay, the co-pilot is there, and I'm the pilot, and we work well together. So that's a system that's been developed over time, and hopefully we can do something similar with technology.
No, thank you. Andrea?
Well, I think that the workforce is definitely an issue for all of us, and in particular for psychiatry, for mental health. The problem is burnout, the problem is among the young generation. The problem, I think, is also that in many countries, mental health and psychiatry in general are not so attractive. So I think that we should try to think how we can rebuild the way also we make our assistance and treatment, starting from the places of care, which are also extremely important. Many young colleagues or medical students still think that psychiatry is made in old fashioned asylums, separated by the rest of medicine. So I think that the image that we give to the workforce is important. The second point is that we need to improve the collaboration among the other specialties, but also to differentiate the tasks and abilities. We have many workforce in our field that are not used is not the right term, but it's not properly addressed. For example, community psychiatric nurses in many countries, or rehabilitation technicians, or social workers and psychologists and psychiatrists and child and adolescent psychiatrists. So it's important to have a lifespan approach to all problems of people facing mental health issues. And also taking into account the lifespan approach, because we need to be attractive for young people facing mental health problems, and for young ladies with problems during the peripartum period, or for old age psychiatrists and mental health issues. So this is extremely, I think, something that we can do quite easily. Of course, it requires a collaboration among the different stakeholders and governmental agencies and professionals.
Thank you. So I think what I'm going to do is pick up on this group therapy point. And we all know that it's important to have something positive and uplifting at the close. So what in fact, Andrea, I seem to remember the two of us wrote an editorial some years ago about why there's hope for psychiatry. So just to close, I'd like to ask each of you just to name one positive thing, positive development, anything positive from your respective professions that helps contribute to this hope for the future.
I like your positive attitude. I love a psychiatrist. Can I say 1.5? So we have the IGAP plan, which is the WHO plan to improve the management and the care of neurological disorder, epilepsy and all the other neurological disorder, which is a fantastic plan which we are trying to implement in each single countries because the WHO has suggested that. And also we have the brain health campaign, and you are all working with this in this project, which is quite exciting and very positive and full of passion for everybody.
Thank you.
Thank you. Maybe two little ones. So in some countries, there has been a nice development of career pathways for mental health and psychiatric nurses, and I think that's important. If you can see the future, that there is a future to go That might be the master's programs for mental health nurses or psychiatric nurses, but it could be also the multidisciplinary master's programs in mental health, which might be very, very attractive to some people. But I think the most important and most positive message is coming from a little national study that I'm doing at the moment with my colleague, where people are telling that what is keeping them at the work is the work that they are doing with the people, meaning patients, clients, families, and other professionals. So even with a lower salary, even with the poor management, they are still there because they want to work with people. And I think that's very, very important message. That's actually many times the reason why we have entered these professions, and sometimes we tend to just forget it for a while. But maybe we can put some more emphasis there and more kind of strongly making it visible how important is it to work with the people and how we can help each other. This kind of a more societal or community approach. So that may be the message that we should listen more carefully.
Thank you. I have noticed how the speakers are trying to introduce multiple positive things, but I suppose that's a good thing. John?
I'd like to mention lots of things, but in the spirit of the point you just made, I'll stick to one. One probably concrete example just of a lot of the themes we've mentioned that we focused on within EFPA is we've participated in the European-funded H-Work project, which is focused on workplace mental health and well-being. A lot of good people involved in that, and we were happy to be one of the participants. But it was just an interesting example, picking up on some of the points that we mentioned, because again, we've obviously had work in organizational psychology, but then you have more clinical forms of psychology, maybe a slightly different things. So it's an interesting project in bringing them together, and then including digitalization and having an online platform, and also focusing on the prevention aspects as well. And how do we, again, I'm sure we all have this, those of us who are practitioners, where somebody arrives and says, well, work is the problem, you know, and you're working with them on that. But to bring in those preventative elements and to help kind of create a culture, I suppose, of organizations really thinking about this, having metrics and assessment and knowing where well-being is. So this is, I think, it's one of many examples. There are lots of different domains where this type of work can happen in, but I think that would be lovely to see, because it creates a culture of mental health then and awareness around it, and it keeps clinicians doing the specialist work they're doing, but it somewhat shares the burden, I suppose, so things don't have to get quite so critical.
Thank you. Andrea?
Yeah, that paper Julian was referring to, it was This Is Why There Is Hope for Psychiatry, and it was actually, I would say, a response to a paper, a very important one that came out at that period, which was Are Psychiatrists an Endangered Species? You will remember that. And in that paper there were 6 criticisms to psychiatry and to mental health from inside and outside the profession. And we try to give an answer, a positive answer, according to the Julian approach to life, a positive one. We try to do that, and actually I think many of those are still in place. But I would like to add a couple of things, I think, which are important to highlight. One is that now mental health is, knowledge is about mental health, about mental disorders is increasing. We know much more than before. There is this project of the brain health in which mental health is definitely involved. We know that mental disorders are disorders which are located in the brain, but that are related to function with the external life, so in which we are all immersed, which is psychological life and social life. So this interaction, we know the vulnerability, the biological or genetic vulnerability, and we know that we have several psychosocial stressors along the life according to the biopsychosocial model of mental health. And we also have improved a lot our treatment, we have refined them. Now we are looking also much more than in the past to issues which are extremely important for the life of the person, which are ethics, dignity, respect, autonomy. These are all aspects that 20 years ago or 30 years ago were not considered as important as they are now. And the last thing I think that is extremely important to highlight is that now patients themselves consider psychiatry and mental health differently from the past, so they are allied, and according to now the new approach of shared decision making, we can make better treatment for our patients.
Thank you very much. So I'd like to say a big thank you to all four of the panel speakers. Elena Morrow, Nina Kulku, John Francis Leader, and Andrea Pirillo. Thank you so much. So the last presentation before we have a coffee break will be about the EPA Ambassadors Survey 2024. And presenting that will be the person who's been the driving force behind this, Professor Martina Rojnik-Kuzman, who is a psychiatrist from Zagreb in Croatia, and importantly also the treasurer of the association. So we are always very polite to Martina. Thank you very much.
Thank you very much for this kind introduction, and good day again to everyone, and thank you for coming and for being us from the very beginning of the Congress. So I'm going to introduce you the EPA Ambassador Program. This is a program from the EPA that was initiated in 2020 and under the leadership of Professor Philip Gorwood, and I continued with him. So this is actually a program where it operates through a series of surveys, and we want to ask clinicians all around Europe to say their preferences about different topics which are of interest in the particular time. And so we started with 2020 asking our members and psychiatrists all around Europe about their organization of mental health during the COVID pandemics. And these, as all other surveys, have been also published in the European Psychiatry. The second survey was in 2021. It was a survey based on preferences of clinical decision-making styles. And we wanted to ask which are the clinical decision-making styles all across Europe. And the survey was done in 38 countries. And this is just one of the pictures from the surveys. And you can see here that across Europe, in a majority of countries, we as psychiatrists make decisions which are shared together with patients. But in some of the countries, like northern countries or Western countries, the decision is more made by patients, where on the other side, on the Eastern European countries, the clinical decisions are more made by the psychiatrist. The 2022 survey was on a topic on PTSD, and for the first time we had used a different design. So we designed two clinical vignettes, one of the patient with PTSD with civil origin and another of patient with PTSD with war origin. And what we asked our participants is to give their treatment preferences of these specific cases. And this survey, as all the others, reached a response rate of about 900 participants. And so the data are, I'm just going to give you one example of the data, because the data are actually in full published recently, a month ago, in European Psychiatry. So basically, here are some of the results. We found that when analyzing the differences between Northern European countries, Southern European countries, Western European countries and Central European countries, there are differences in the treatment preferences for patients for treatment of PTSD. For example, in Northern countries, they have lower preferences for any antidepressants, where, for example, when we are looking for specific antidepressants, in, for example, Northern countries, there is a preference for mirtazapine, where, for example, in countries like Southern Europe or Central European countries, there is a preference for trazodone. Also, in these countries, there is a preference for benzodiazepines, where, for example, benzodiazepines are very rarely prescribed in Northern European countries. We also did a Latin class analysis. This is on the right corner there, which means that we seeked whether there are different types of prescribers within the sample. And so we were able to locate 4 different groups of prescribers. So one type or one group of prescribers would prescribe conventional antidepressant. The other group would prescribe trazodone together with exposure therapy. The third group would prescribe mirtazapine together with EMDR. and the fourth group would prescribe comprehensive medication, meaning antidepressants and other medication together with cognitive processing. And basically, we found that there was differences, and usually what we do in these instances that we rely on guidelines. And so we try to tackle all these differences within a country and between the countries and within the country with guidelines and say, okay, this is the best practice and we think this is how this should be treated. But when we ask the same participants about how much they use guidelines, we found that about 50% of participants do not consult any guidelines when they are treating patients with PTSD, regardless of where they come from. So it doesn't matter what is the region they're pertaining to. And this actually is how we defined what we are going to do for survey 2023. And we focused on schizophrenia, because also there was a project initiated by the former president, Professor Falkai, who actually wanted to make a guideline which incorporates all the guidelines within Europe and also try to make responses to some of the questions within the guidelines using clinical consensus. And therefore, the idea was here to make 7 different cases describing different phases of schizophrenia, or patients with schizophrenia, and ask about the preference of how they would treat this specific situation. And we also had acquired this sample size, and these data are only preliminary, so the analysis is done on the whole sample and not on the differences. And so just give you the example of 3 cases. So the first was a question of a patient with prodromal phase, and we asked about the preferences for treatment. And you can see here, the majority would say that would not apply any of the medication, antipsychotic medication. Some would apply aripiprazole, quetiapine, or olanzapine. When we ask for other medications, so not antipsychotics, a third would apply one of the antidepressants or the other, but basically antidepressant of SSRI type. And when we ask about other non-pharmacological methods, the majority would apply cognitive behavioral therapy, psychoeducation, and lifestyle recommendation. One of the other cases was on patients who had symptoms pertaining from negative and cognitive domain. And when we ask about the preference of treatment, so the majority would say would be treated with aripiprazole, cariprazine, or risperidone. And when we ask about other medication, none, escitalopram or sertraline again, and other non-pharmacological methods were similar with the first phase. The third was a case of a patient who is pregnant. And again, when we ask, this would be the preferences. So aripiprazole, or I would not apply any medication, or quetiapine. For other medication, the majority would not apply any of the medication, or some supplements, or diazepam in lower cases, and other non-pharmacological methods. When we ask about how many of participants would comply or consult any of the guidelines, here is a much better situation, which means that there is a lower number of those who would not comply to the guidelines, which means that actually the guidelines for schizophrenia somehow reach a wider audience or are better probably implemented compared to other guidelines, which is, I think, a good, actually good result and a positive ones to finish with something positive. And then I would like to thank all those who have fulfilled the survey. These are just people who said that we can say them thank publicly, but I would like to thank all the others, because especially this last survey was quite extensive. The 7 cases took much of the time, and I'm very, very helpful to all of you who have fulfilled the survey. And I also would like to invite you for the next one. This next one is a bipolar disorder, and this is a survey which is shorter. It will take it from 10 to 15 minutes of your time. So I'm very thankful for you to your devoted time already, and I really hope that we can somehow make with this survey, together with complementing with guidelines, to make a way how we could really harmonize some practices and really implement the guidelines, because sometimes it seems that the guidelines are existing and somehow also used and promoted by scientists, but not so much picked up by clinicians. And there is probably an area of divergence, and we, I think, should work more on how to make this somehow one closer to another, so to better implement the guidelines and in the end have harmonized and better care for the patient. So thank you very much for the attention.
Thank you very much, Martina. So this brings us very nicely now to a time for the coffee break. Because of the late start, we'll just move the timing slightly. So I'm going to ask people to be back in the hall by 11. So we will start the next session promptly at 11 o'clock. The refreshments, you can use the exits at both sides. See you soon. Hello everyone and welcome back to next session. I'm just going to very briefly introduce Joan Marsh, who's the editor-in-chief of Lancet Psychiatry, and she will be moderating this session. So without further ado, over to you, Joan.
Thank you, Julian. So I just wanted to show 3 quick slides before I invite my panel to start talking, because this is what we're doing at Lancet Psychiatry. We're really keen on inclusion and trying to move this forward from what we can do as a journal. So all our covers are done by people with lived experience. This is Laura Fisher, and she's doing the covers this year with a group called Traumascapes Survivors. Next slide. Oh, sorry, I'm in. Thank you, Margaret. Not organised here. Ding. Where am I zooming? What am I pointing at? Anyone know? There we go. Yep. No, we've gone to that's coming back. Right. As you can see, we've rehearsed this. I thought that I had 3 slides, but perhaps I haven't. But what we are doing, so 2 things on my missing slides. One is we published a comment in January. We're running a pilot this year asking authors to declare in their papers whether or not anyone with lived experience was involved in any part of the study, from design through to write-up. They don't have to have been. We're just asking them to explain if there was that input. And in the abstract, that will be mentioned. If there was no lived experience input for certain types of studies like clinical trials, where you would really want service design, where you really want input, that will be declared as a limitation. So we're running that pilot for 6 months, and then we'll assess the results, but I'm hoping we'll roll out and move on with that. And then we also have in progress a commission on the role of lived experience in the whole of mental health research. And that's working hard now, and hopefully will be published next year. And they have a session at ECMP, if anyone's going there, just to promote the competition. Right. So that is my comment. That's the comment, which was published in January, and that's the commission. Right. And then we'll move on. So we're now going to our panel, and I posed you 4 questions, which I have on my phone. So I'm going to start with Cyrus. So the first question I posed to the panel was the longest. So what solutions do we have for more inclusive healthcare that operate at the level of the individual healthcare staff, and the level of healthcare system? So what solutions do we have at the moment at any or all levels? Cyrus.
Thank you very much, and thank you for inviting me to this wonderful congress here in Budapest. I'm a member of the European Parliament, and obviously we work on legislation, we work on policy as elected decision makers. And I really agree with what you had in the first slide, which said nothing about us without us. And obviously, in the work that we do, we need to make sure that when we're discussing any kind of legislation which affects different people, we actually listen to those people and have those people on the deciding seats themselves. It is something which I have tried to do during my mandate, which is now coming to an end in 3 weeks' time, as we all move towards European elections now in June, where we were a small group of members who tried to discuss issues by having the actual people affected by those laws and policies sitting on the table, on the decision table. Because I remember we were discussing, for instance, sex workers and their rights. And I used to go into rooms full of middle-aged, white, straight men to discuss the realities of different sex workers. And I thought, this is rather strange. I mean, they might have the best of knowledge of what sex workers do and need, but where are the sex workers themselves, so to speak? So in all contexts, whether we're speaking of sex workers in that case, or other issues like mental health, we need to hear the people who are actually affected by the policies that we're working on. Whether we're speaking of patients, and I had a great experience listening to Peter this morning about his personal experience when it comes to combating mental health. We had the members of families, but then in the previous panels I heard from psychotherapists, psychiatrists, psychologists, and those actually nurses who are working on the actual in the actual field in order to understand the different needs in the sector and be able to come up with our proposals. I'm happy that finally the European Commission has come up with a small step so far, because I'm the co-president of the Mental Health Alliance within the European Union. We've been pushing the European Commission to come up with a European mental health strategy. And unfortunately, this hasn't come to light yet, but we have the first initiative, which is a good step forward. And I hope that in the next 5 years, we'll have a strong commitment by the European Commission on mental health. But inclusiveness needs to be much more than that. So we need to include patients, families, all those who work in this sector, but then we need to also see this in an intersectional approach. And being in Budapest, in Hungary, I cannot not mention the realities of different minorities in this country that are currently going through huge mental health turmoil because of the policies of this country. And I'm particularly speaking, we heard about migrants this morning, but I'll also speak of the LGBTIQ community here in Hungary. We know the numbers because of the policies of the current government, where 42% of LGBTIQ people here in Hungary have thought about suicide. 30% have attempted suicide. And this is the reality when we have policies and politics that is not inclusive and that simply puts certain members of our society at the side and treats them as if they're the enemies of the state.
Thank you very much. So now we're going to Lady Latseri. Thank you, Cyrus. So Ladia is the regional advisor for mental health from WHO Europe. Ladia.
Thank you, John. And while I fully endorse Cyrus's messages about inclusivity, I'd like also to focus on how the question is formulated, finding solutions to more inclusive mental health care. And while solutions are many, I'd like to focus on what is not a solution. And what is not a solution is standalone psychiatric units, be those inpatient, outpatient, community-based, primary healthcare level, but standalone psychiatric units that do, because they stand alone, the service they offer is symptom management. And then when the patient graduates out of that service, they go back to what Sir Michael Marmot says. They go back to those conditions that in the first place generated their poor mental health. So a standalone psychiatric service is not the solution. The solution is a service that works in coherence with other aspects within the healthcare, different levels. So usually in many of the countries of the WHO European region, that is 53 member states. So the WHO European region is a very wide region. It is very diverse. So for those in the audience who probably do not relate to what I'm saying, please remember that I'm trying to be inclusive of all the 53 member states. So many, I'm not saying most, but many of our member states do practice psychiatric care into small isolated units that are very often out of the community, out of towns, and those are not the solutions because they perpetuate the segregation that is born out of stigma, discrimination around people with mental illness. So in a way they create, or they are part of the vicious circle or vicious spiral that further and further marginalizes and excludes persons with, that live with mental health conditions. And when it comes to solution, because in WHO we believe very much that one of the main barriers to inclusive mental health care is stigma and discrimination, and following the publication of the Lancet Commission on Ending Stigma and Discrimination in 2022, we are working together with Graham Thornycroft and his team at King's College to develop an anti-stigma toolkit that should be a resource for all mental health professionals, persons with lived experience, everybody in the community that would like to take some information in and apply those principles in their work, be that a workplace, be that a mental health service, be that a public place. In addition to that, we're working in frame of what you said. You mentioned the European Commission. We, in frame of a collaboration we are having with the European Commission, we are also trying to develop some modules that will aim at what we call it is professionalization of lived experience. Not everybody is happy with the wording. Another wording is co-creation, but basically it's standardizing or giving some tools across Europe to agencies, to partners that need to involve people with mental health, with lived mental health experience into service delivery, service planning, policy design, and so on and so forth. And that there is always resistance against that. Of course, part of that resistance is stigma, but one way how the resistance is used is, oh, but these people are not trained. Oh, but there is no quality assurance to involve these people into the service delivery, policy design, and so on, and measuring and evaluation, so that we're trying to together, of course, as a co-creation with persons with lived experience, advocacy organizations, we're trying to develop that module or set of modules that would allow a meaningful inclusion of persons with lived experience in legislative processes, in policy designs, in service implementation and delivery. Thank you.
Thank you, Lydia. We're getting applause here. We didn't get applause first time, so that's great. So next up we have Doron Vishka.
Weiker, very close.
Weiker, sorry, should have practiced this before. I got Doron.
If there's any Dutch people in the room, you will.
So Doron works for the OECD in Paris. Over to you.
Yes, thank you very much for the invitation. It's great to be here. So let me start briefly by introducing the OECD for anyone who might not be familiar. We're an international organization. We work across 38 member countries across the world to promote policies that will improve social and economic well-being. And mental health is very much a priority for us, so it's great to be a part of this conversation. When thinking about solutions to more inclusive mental health care, I wanted to reflect briefly first on the links between exclusion and mental health. And I think we heard very powerfully this morning that those links are complicated, but they're also two-directional. So we know that people at risk of social exclusion are also at heightened risk of experiencing mental ill health. We also know that people experiencing mental ill health are at heightened risk of social and economic exclusion. And we've heard very powerfully this morning about the role that stigma might play in that. So in our work, we've seen that people with a mental health condition are 20% less likely to be in employment. Students with mental distress are 35% more likely to repeat a grade at school. And so we have these really close links between exclusion and mental health, and that means we cannot address them in isolation from one another. And so for us, I really want to think about inclusion from the perspective of a full systems inclusion approach to mental health that looks at integrated mental health, skills, work, and education policy. There are examples of good practice. So we see across Europe, for example, that there are supported employment programs being trialed and implemented, and that's very positive. But unfortunately, systematic integration of mental health, skills, work, and social protection policy is still by far the exception rather than the norm.
Thank you. Okay, there is a second microphone. No. It just there seemed to be a boys' one and a girls' one. So we now have our esteemed president, Geert Dom, whom you all saw earlier, but Geert.
Thank you, Joanne, for this very complex...
I'm not sure that one's working. You can have the girl's microphone.
The girl... I feel excluded. Now it's working. Thank you. So thank you. These are very complex questions and so difficult to answer. And I think inclusion is a super. So I will try to follow your schedule a little bit from individual, etc. But first, two general remarks. First of all, we are human beings, and for human beings, inclusion is essential. So exclusion makes you sick, whatever you say. Secondly, I think we can talk a lot about inclusion in health and in mental health, but basically this is a reflection of societal inclusion or exclusion. So I think we're there on a very difficult point where we stand in the dialogue, so it is impossible, I think, or quasi-impossible to be inclusive in mental health if you live in an exclusive society and things, so there's a lot of overlap. Thirdly, as a general remark, you ask about individual staff and higher up. I think we need to start earlier. I think the detrimental effects of inclusion/exclusion are happening at the level before any disorder happens. And so if we really need to think about what can be done, I think we need to talk about prevention, and I need to think that we need to develop programs and plans where we in schools and go further in education, where there we focus on the inclusion and starting from there, and I think building up resilience before, and I think there the most gain is to be one. Now I will answer your question. Individual level, there's a lot to be done, but I was struck by what André said about the Swiss study earlier on. Of course, I think inclusion means working with the patient, working with the environment much more. And when I heard the data, so many family members working and giving support, and we don't finance them, for example. They're not included in the help and care system. So that is just an example how we can work more inclusive on that level. There are many examples. Jump up one other level on the team levels. Well, maybe it would be already a big help if our team composition would resemble a little bit the composition of the patients they treat, both in gender distribution as in other and cultural distribution, etc. So it will be help grateful. And jumping up to the higher level, the organization of care, etc., I think we connect again with the prevention, because there we touch again up all the societal equalities and non-equalities. And we know, I think, what should be done to be inclusive. We know that we need to diminish social economic inequality and pull it further, and that it will help, and that it will reflect in how the care system and how the money for the care system is distributed. This is a humble effect too. Thank you very much.
Thank you, Geert. So we now have John Leader, who those of you who've been here all morning will see John. John has kindly stepped in to replace someone who couldn't make it. So he hasn't seen the questions before. So can you remember the question, John? Because it was very long.
I feel honored to be able to build on those great answers, which I just repeat what, yeah, exactly. We, the European Federation for Psychologists Associations, EFPA, in the build-up to the European Commission's comprehensive approach to mental health, the call, the various consultations that happen around then, it was a very interesting exercise to think about, what does inclusion look like in an approach to mental health that actually does justice to the topic. And we came up with 7 principles, 7 pillars that we worked with. And what they focused on really were different contexts around mental health. 2 particular to pick up on. One, community-oriented services. So WHO, needless to say, is doing extensive work on that. And I think that's very important, because I suppose to include an individual is to include their context as well. And we know that from a research perspective that, even if you conduct the study right, but the context is wrong, you're in a white, sterile room rather than the real world setting, you're going to have issues with ecological validity really that come up as part of that. So I think that's a big part of inclusion, is getting that right. And more community-oriented approaches do us all favors, of course, from a resource perspective, as well as being where you will find people. In Ireland, where I come from, and I'm sure it's the same principle in many other parts of Europe, GPs I spoke to, and I have them in the family, general practitioners, say that, you know, a big thing for me was going to the home of the patient, seeing their context, and walking in, and a lot of the diagnosis happening in those first few moments when you got the feeling or the sense of the location and the conditions and the circumstances a person was in. So I think that's important. One of the other principles, just to mention, around accessibility is on the digital level as well. And that's an interesting one, because it's almost to do with the languages people speak. You can, of course, by taking a strongly digital approach, you might exclude some people who don't have even internet access, much less skills and competencies around advanced technologies. So that's something we've got to be very careful about. However, also the reverse risk is there. Sometimes we can be a bit purist, I think, the other way and say, well, you have to do your therapy in a room. But for somebody who is a digital native who spends all their time messaging and has social anxiety, actually that online platform might be their context in a sense. So just a couple of reflections, but I think if we're really taking this seriously, taking an extended approach, considering context, and really just making sure that an all policies approach, an inclusion in all policies approach is something it's just a culture. It just feels wrong not to take it into account with each part of the process.
Thank you, John. So we have consensus that inclusion is a good thing, and there are various ways to approach it, various ways not to approach it, so we need to move away from psychiatric hospitals. So I'm just going to go around one more round of questions. So either what are the barriers to getting away? So the solutions you mentioned, what are the barriers to those? Or what research do we need to address those barriers and to move to the next stage? So what do we need to be doing in the next 10 years? I think we'll start with Cyrus again.
Thank you. So what do we need to do in the next 10 years? There's so much to do, I believe, which would require a very long time to answer. However, if I can think of a number of issues that come up at first in my mind, firstly, we need to have much more funding at European level, especially when it comes to research on mental health. But we also need to diversify the way that we actually work on research when it comes to mental health. I know I've met a number of you, like John and some others, during the past years, and we've discussed the way that research is being done and how sometimes it's easy to focus on what has been traditionally done. I saw in the presentation before the different treatments that are given in the different parts of Europe, North and South, West and East. However, we already know as well about the research being held at the moment on psychedelics, for instance, for mental health. Is that something that we need to fund even further, to have more research, to see the studies of the clinical trials that are happening both in the US and in Europe, and what's the way forward with those? But apart from funding, etc., I think we really need to listen much, much more to those who are working in the field, but also, and I speak as a decision maker now, those who are working in the field and those who have experienced the different approaches, let's say, to their own treatment. Yesterday, in my country, in Malta, a group of 2 young people who have been institutionalized in our only mental health hospital on the island launched a new initiative called YANA, You Are Not Alone, where what they experienced was that the minute that they were sent to the hospital, they had nothing. They were immediately sent to a hospital with nothing in hand, nothing at all of their possessions, of anything that they could have. And they started this initiative to have this small bag that will be given to new entrants to the mental health hospital, so that at least they would have some of the basic things that you would need the minute you are admitted to a hospital. And this made me realize how much, first of all, certain things are taken for granted, but how much at policy level we need to make sure that people who need the treatment, who unfortunately sometimes would need to be hospitalized. I'm always one of those who believes that we should have more community care rather than hospitalization, but sometimes that is needed as well. But we need to understand what those patients need also, not only from the mental health perspective, but for their own being at the moment that they are admitted to hospital. And I really admire people like Emma and her friend who are doing this, that shows that there are so many facets that we need to look at, and not only one. And in order for us to be able to come up with policies that better the situation of those people, and I continue mentioning this, we really need to listen to everyone in the room and make sure that the thoughts of everyone are taken into consideration when deciding on how things are actually done.
Thank you, Mohan. Yeah, and you are here with us, listening to us, and hopefully you're going to go on battling to get us more funding. So thank you very much. Right, Lydia.
I'll take from you started with the budget, and I will also bring a story from someone that comes from one of those countries in the WHO European region that still use 98% of their mental health budgets into mental asylums. And this is a woman that 10 years ago, a young, relatively young woman, that more than 10 years ago was sent to one of those mental asylums. And she said that she knew when she was locked up into one of those asylums, she said that she was supposed to stay there for life. And she lost all her rights, right to property, right to education, right to employment, right to freedom, basically. And then, but she said, but I was still a person. And this is a person that, as psychiatrists, we would all recognize that this is a person that has received for a very long time large doses of antipsychotics, because you could see the side effects in her appearance. And she said, but it was very strong when she said, I was still a person. So what brings me to the budget now? Because you called for more budgets, and that is undisputed. There is not a single country that is investing sufficiently in mental health. But it's also a matter how those budgets are used. Because as I mentioned, this is a country that uses 98% of its budget on mental asylum. And as many of us in this room know, those mental asylums do not serve therapeutic purposes. They are there to contain people that sometimes have been very disturbed. They might have had very severe symptoms, but then once those symptoms are controlled, then the rest of their stay in the asylum doesn't serve a purpose. So why are public budgets invested into institutions that are not only questionably treating the rights of the people, but also are not serving any therapeutic purpose? So the first point in my telling here is using more budget, but also using budgets better. And the second point, there are so many points, I'm intimidated by how large the range is, but the second point I want to make is measure and evaluate. Because most of our member states have beautiful, beautiful policies. There is virtually no member state among the 53 countries that we are working with that do not have a policy that is sometimes very, very good, outstanding, and sometimes acceptable. But then they are either not implemented, or they are implemented with no measurement, no monitoring about how effective they are, the interventions that are applied, how effective they are, and then coming back to the budget, then by not monitoring what is implemented and what has been the benefit, then you end up with those historic budgets. More than 1/3 of our member states, if not half, are using budgeting on historical ground. So you had $100 used for this hospital last year, adjusted by inflation, and then voila, this year it's $102.3. And there is no thinking behind what is the need. The need has evolved. We probably have more refugees in our midst. Probably because of COVID, we have more young people that have attempted suicide, or more young people that are displaying anxiety and depressive disorders. So where is the thinking behind planning for the use of those poor budgets that we have? So not only we are spending insufficiently, but we are also not spending efficiently. And this is a reflection that I believe not only the policymakers and the decision makers should make, but also I think that should be a wake-up call for also the professional communities, because at the end, many of us in the room, regardless of where we sit, if we are ahead of a service or not, we would probably be asked as psychiatrists by someone, what do you think this service, how do you think this service can be improved? So if we can see each and every one of us as a player that can have a voice and say something, I think things can improve. Thank you.
Thank you, Lydia. Doran.
Thank you very much. I'd like to build on both of those really great points, actually. I think we heard quite powerfully about the role of resources here. So there is a big piece about removing financial barriers to care. And I think over and above that, beyond bringing more people into treatment, I think we also really need to look at the way that we assess, from a policy perspective, the quality and outcomes of treatment. And I think we really need to put people at the center of those assessments. Historically, this has been a very big gap, so countries tend to measure the performance of mental health systems by inputs and processes, rather than whether or not they're actually making a meaningful difference to people's lives, and whether they're making a difference in the areas of people's lives that matter most. So this is a gap that we're working partly to fill, so we're really trying to promote and harmonize the use of patient-reported outcome and experience measures. And at their best, really, that should be a very practical tool that will help conversations between people and practitioners about the progress and the outcomes of their treatment. And also then a tool that can make sure that those conversations are fed into national conversations about how well the mental health system is actually performing. So really, it is a tool, if you like, to elevate patients' voice and to ensure that it's systematically included in policy and practice.
Thank you, Darren. Okay. Yeah.
Thank you very much. Yeah, it won't take long, I think. I keep on emphasizing, if your question is the next 10 years, I think really we should look more into all aspects of prevention, building out school-based programs and investing in that. And I'm so happy for the European Council and its communication and the money that's there provided, that there's a lot of aspects in that go how to build on resilience out for health, for mental health. Counts the same, by the way, for brain health. So I think there's a lot of commonality there, and we need to emphasize that commonality there. So I think that is one important part where the focus should be. Two practical things to end up. First of all, if I see a lot of patients, they drop out and they cannot get into the system. And I have a little bit of feeling that the more excluded you are, the more difficult and complicated it is, procedure-wise, and all the things you have to do to get in the system. You have to have a PhD to get from the street and to get all the money you write, etc., etc. So I see a lot of patients going loose. So I would ask not for money for politics, of course I do that, but please make systems simpler. Just making systems simpler throughout Europe will help a lot of people to get much more easily included. And finally, I should not say it as president of this association, but maybe we should be a little bit self-critic too. I see a lot of patients, they say, I went to that service and I was not admitted because I had not the right diagnosis, and then there was another problem and I couldn't get there, etc., etc. Sometimes I wonder whether we are not too highly specialized and too diagnosis focused, etc. So maybe some self-analysis would be also a good thing to start for ourselves on inclusively. But I didn't tell that, so please keep secret on that.
Thank you. And then John.
A caution, I think, with inclusion is that it doesn't become a brand, a label, it doesn't become something trendy. Isn't that the risk here? Because there's a sense in which you don't do something, and then you start to do it, and it becomes cool to do it, and then everybody's, and kind of it loses its meaning a little bit behind that. So, as you have all said, I think in different ways, taking really concrete steps, kind of really auditing the way that we are inclusive, I think is going to be really, really critical. Just to touch on a couple of levels. On the European level, that I suppose was one of the hopes, and it still is the hope. Cyrus, if you can figure this out over the next while, that'd be much appreciated. For the comprehensive approach to be a kind of a unifying framework, I suppose, is really the hope. Because there's this question of healthcare being a national competency, and maybe that means on a European level we need to be a bit careful in that. But I see that almost as an advantage in a way, because really where the European level works well is in the coordination, is in creating the culture, is in uniting and connecting resources that are there. So I think if we can really push to make sure that that happens well, that's going to be very good, and inclusion being built in there is going to be important. On the level of our various associations, regional bodies and national associations, again, making sure that is inclusion actually happening in the decision-making processes, in the way data is gathered and looked at. And then just actually on the ground on a more local level, as practitioners, are we co-creating really in terms of the process? That has to be the culture. And one personal example, if I can use just from my own research in University College Dublin, where we look at building simulations to help people deal with stress, trauma, phobias, those kinds of things. It really became clear that it was a win-win to include people with lived experience because, of course, firstly, they knew what they were talking about in terms of creating environments that would actually help them with their challenges. But the other thing is the average mental health practitioner isn't a very good software engineer or graphic designer or whatever other skills that you mentioned. So one of the things we're working with, just as a very simple example, is bringing in people with lived experience who help create therapeutic environments to process trauma and to deal with those kinds of challenges in. So I think things like that are good examples of how the different competencies can come together. The lived experience and even therapeutic processes and various interventions can really be shared with still the specialisms there so that the standards are kept very high, which is really important, but also the lived experience brought in, which actually helps with resources. So in the short term, it might be a bit tricky, but in the medium to longer term, I'd like to think it will use far fewer resources to really share the burden and to be properly inclusive in a practical way.
Oh, thank you. Right, so thank you very much to the panel. You have been applauding them as we go, but let's give them all a big round of applause now. And I'm handing back to Julian.
So, thank you very much, Joan, and thank you very much to all of you on the panel for what has been a really interesting discussion. Now is your chance as the audience to be able to ask questions. So we have microphones that are standing microphones. You will see on each side there's a microphone, and if you'd like.
We can't see anything. We can't see much because of the lights. So someone's pointing that way. There we are. There's someone at the microphone. Julian, someone there.
Is it on? Yes, it is.
So,
may I?
So, 1 second. So we will have questions from the audience. I'd invite people who want to ask questions to go and stand at the microphones, and I will do my best to see you, but if I'm not responding, just wave your arms around. So Silvana, please.
Thank you very much, Julian, and thanks to the panel for this very interesting conversation. I just want to highlight the point of the resources. Of course, all of you pointed out the importance, but I would strongly disagree on the point that it is not a matter of resources, but of organization and the way in which resources are invested. I come from a country where, since many decades, we don't have any psychiatric hospital. We don't have asylum. I come from Italy. So it has been a long way through community services. But still, after so many decades, the quality of mental health services is not satisfactory. Community mental health services is not satisfactory. And you know why? Because there is not much investment in health, but mental health is at the very, very low end of the, in Europe, we are, I think only 2 countries receive less resources than Italy. And the budget is 3% of the health budget, which is already not enough. But still, we are still regarded as the last ones. So I think this is really a problem that must be taken very seriously, because people working in mental health services are not motivated. They are exposed to burnout because the burden is really too much. And I think that digitalization might be helpful, but certainly is not the solution. Many people are not happy with mental health services because they are supposed to be given at least audience, time, attention, psychotherapy, psychosocial programs, but all of this requires a lot of resources, human and financial, because these two go together. You cannot have good human resources if you do not have financial resources. If you have financial resources, you can provide training, and you can have more and better human resources. But if all of this is not covered, you're not going to have anything, and people will be very dissatisfied. And also, I would really caution everyone who says this person received antipsychotics and the appearance was speaking towards antipsychotic treatment. We should not blame antipsychotic treatment because that's life-saving. But we should blame the fact that only antipsychotic treatment is provided. And this must always be very, very clear, because otherwise we run the risk of stigmatizing our treatments and once again discouraging people from coming to psychiatry and to mental health services, which is extremely important but still must receive the same level of esteem as all physical health.
So
I will stop here. Thank you very much.
Thank you so much, Silvana. Now, I'm going to use my discretion as moderator to say, Cyrus, that sounds like a question for you, but I want to just rephrase it slightly, which is, from your perspective, what do you think we could do that might help unlock more attention to funding from a political perspective?
We need to put mental health at the top of the agenda, because it hasn't been. I just remember when we started the European Mental Health Alliance in the European Parliament, and we had a call out for those members of the European Parliament, so we're 705 in this mandate, for those who would be interested in joining this alliance. It was, out of the 705, I believe only 5 female members of the European Parliament and myself. And that speaks volumes as to the priority that we give to mental health. Now, obviously, I'm not expecting everyone to focus on this area when we're working on defense, foreign policy, digital things, civil liberties, justice, home affairs. You know, there's a lot of things going on. However, to have only 6 members of the European Parliament that are actually interested in having this new group and leading it, for me, that raised a lot of alarm bells. Because until we understand that this is as important as all other sectors, I dare to add, if not even more, because how can we have all the others if we do not have healthy human beings, both physically and mentally? But if there is this reluctance to actually speak about, move forward, put this at the top of our agenda, then how can we arrive at having mental health policies at EU level and strategies that also would include better funding?
Sure. Thank you. Geert?
Yes, thank you for allowing, and thank you, Professor Galdaresi, for raising very important points. I just want to share one concern in reaction to what you said. I believe you. I think we need to put mental health first, and I think there's a lot moving around that. In the media, in the population, there's so much going on about mental well-being, mental health. I was very positive on your communication, and I'm still positive on the communication and the money that's provided there, and it's all in the direction of mental well-being and prevention. But my fear is that patients with a serious mental illness are left behind in this process. My fear is that, and I live that, for example, in Belgium, and that there's a lot more money given to mental health. It's going into the direction of prevention is good, schools is good, first-line psychology is good. But then I ask, where is for patients with severe mental illness? Then they say, well, we give a lot of money. You see, mental health first. So I really thank you, because I think, and I would warn and I would ask you also as a politician, yes, mental health is good, mental well-being is good, but don't forget this small portion of the population where you have very severe mental illness, where there are lots of problems, where there are lots of family stress, etc. Don't forget these people.
So thank you very much. So just to make sure that we can get in as many questions as possible, I'm just going to, so the sequence for questions will be the lady at the back, and then the person over here, and number 3, 1, 2, 3, okay? And then I'd ask people just to keep their comments or their questions fairly brief, if that's okay. And if you ask a question, tell us who you want to answer it. Thank you. Please.
Just keep talking.
There you go.
Am I on now? Yes. I'm a psychiatric nurse practitioner from the United States. Just like we are no longer a model for democracy, we're also no longer, or haven't been for some time, a model for mental health. I think the US pioneered deinstitutionalization. So we don't have asylums any longer. And for the most part, this is a good thing because it has helped protect the rights of people who didn't need to be hospitalized for years and years. However, there is a significant and small group of seriously mentally ill people, and they are not being served well at this time in the United States with the deinstitutionalization. And in fact, we now talk about the prison system as being the largest mental health care provider in the US. I have visited in the prisons and seen what those services look like in my city of Baltimore, Maryland. I wanted to ask any of you whether or not, nobody has talked about prison mental health care in Europe, and I don't know what that looks like. So that's my question. Thank you.
Thanks very much.
Yeah, thank you for raising that. Very, very important. And I recognize what you said about the experience in the US, that the one that followed, the situation that followed the institutionalization and the insufficient placements in community services gave way for people to end up in prisons. This is a phenomenon that is starting to also show in certain pockets in Europe. There will be a conference in Amsterdam later this month about prisons, dedicated to prison mental health. So just to answer to your question, it's a joint conference between WHO Europe and the Netherlands Institute for Forensic Psychiatry. So to answer your question, that this awareness and concern is of course coming to Europe. On the other hand, what I would like to say is that there is also a reckoning of, I know that, for instance, in the European Parliament, there has been some debate, I don't know if you're aware, but some debate about, okay, we should get some questioning about the value of deinstitutionalization for the fear of people ending up in the streets or worse, in the prisons. But that should not kind of, just because ending up in prisons as a person with mental health, with a mental health condition is very bad, that is not a reason not to continue deinstitutionalization where deinstitutionalization is due. Of course, the insufficient answers that have been provided so far should not discourage the deinstitutionalization efforts, because we have ample evidence that not only a lot of institutions do not serve any therapeutic purposes rather than consume public funding for no benefit, but also abuse and a violation of human rights is found there. I was recently in one of our member states where I read very carefully the report produced by the EPA during a country mission, and it was very concerning. The EPA expressed grave concerns about the status of mental hospitals in that particular country. So just to say that because a solution or the implementation of a solution has failed, it does not mean that the opposite of that is better. And so I'd like to be very explicit into that, because we have countries, I know, I listened to the colleague from Italy with great respect, and I share your concerns, but we need to be aware also the EPA is responsible, has members also from countries where the main answer continues to be asylum psychiatry, and this is not good. In 2024, Europe should not afford to continue with that level of care, and if we need to advocate harder for more budgets, and I agree with a colleague from Italy, of course we need more budgets. My point is that even where there is little budget, they can be used better. But it's not to say we don't need more budget. No country has sufficient budget. So sorry, Julian, I took more time. Thank you.
Very quick on the other thing on prisons. Thank you for raising that. I think there's big differences in Europe between countries for all sorts of political and other reasons. Belgium, I should not say it because we here under the patronage of the Belgian presidency, but has been convicted 4 times for not treating well enough the people in prison with mental health issues. They are, just as I said before, one of these groups that I'm afraid will be left behind in all this wave, like we have a lot of attention for mental health. It is not sexy for politics, policy making to invest in this, and it's so important, and I'm glad you will react. So that would be my question also. Don't forget these people.
Yeah, if I could come in quickly on this. I totally agree with you. We should not forget these people. Some of us haven't. I remember only a few months ago, I organized a conference in the European Parliament together with an NGO called Nobody Left Outside, in which on the parliamentary seats we had a prisoner, a former prisoner, a transgender person, a refugee, an asylum seeker, a sex worker, a transgender person, all these people who are usually left outside. And this is why it is so important to listen and bring these people into the conversation on parliamentary seats to actually speak out rather than listening to the usual people in parliament. But this is a very important point when we speak of prisons. Only yesterday in my country, another prisoner has committed suicide, and this shows and amplifies how much important it is to have systems that actually take holistic care of people, whether we're speaking of people in different settings, including in prisons. But what I would also add to this is, apart from the mental health of the prisoners, which is very much important and that we need to tackle for different reasons, there would be some people who would be in prison because of addiction, and that is one strand, but then there are others who have obviously challenges the moment that their liberty is taken away and you're entering into a new phase of your life where you have no freedom. And obviously that needs psychological help as well. But then we also must not forget the families of prisoners, because I've been in touch with so many of them, and sometimes those are also forgotten, and we need to include them in the discussion, especially children of people who are in prison, and the way that this has affected them psychologically. And I mean, this is so vast, but we really need to make sure that everyone is included, including them.
So thank you very much. I'm very keen to get the last two people in to ask questions.
I have to thank you very much about that comment, because it leads directly to what I wanted to say and ask. And it's about the way we formulate our research and publications about those people, inclusion, exclusion, not only regarding psychiatric conditions, but also gender, ethnical issues, and just the groups you mentioned. And we should think about the way we formulate, because sometimes it leads to larger and stronger stigma, and not to what we really want. I understand it's new, it's unusual, but maybe we could have some criteria to not allow the people, the families and the people themselves have got even more stigmatized of what we do.
Thank you very much. I think what I'm going to do, with your permission, is I'm going to take the last question from Lode as well, and then ask you to respond to both. So the last question is from Professor Lode Smith, who many of you will know is the President of the Royal College of Psychiatrists.
There we go. I'm Laddie Smith, President of Royal College of Psychiatrists UK. Thank you very much for this discussion. But there is an issue, which is we know that people who are marginalised and othered are more likely to develop mental health problems and frank mental illness. And then we know that people with mental illness are those who are most likely to be marginalised. it's not simply about stigma. This is about structural discrimination, right from the very start. And what I'm hearing the panel saying is we must remember these people. And of course, they're always an afterthought. And I think, Cyrus, you described it very well. You know, the middle-aged white men and forgetting about the sex workers, not having them in the room. Surely we should be designing our services, our processes, policies, right from the start with those who are most marginalised, which means those who have mental illness. And my question to you is, how do we do that across, not just Europe, but across the world? Because surely, with 1 in 4 or 5 people having a mental health problem, that's where the start should be, not the afterthought.
Thank you very much. Dora?
I have the boys' microphone, sorry. So I think that's an incredibly important point that you raise, and I wholeheartedly agree. There's a very interesting policy document in England, actually, the Inequalities Plan, and there's a phrase in that is so powerful and that I love, which is, you can't treat inequalities. As you say, inequalities emerge far, far earlier in the process. And so I think there are 2 parts to this. There are, as Professor Dom said, this is a lot around prevention and promotion, but it's also, as you say, about making sure that our services are more responsive to the needs of those who use them and are actually created in such a way that they take those inequalities into account. I'll be very brief in my answer here. I think one of the primary tools for addressing this is co-creation. I think that we need to more systematically involve people with lived experience, people who have been marginalized in the creation of services and in the evaluation of services, and to have systematic mechanisms to make sure that those evaluations are factored into decision making.
I come from a very small country, the smallest in the European Union, which makes it easier at times to have one-on-one contact with people, and it is the normality within our electoral system as well, which is very different to all other electoral systems, maybe closer to the British one, but different to the rest of Europe, which makes it a must that those at decision-making positions need to constantly and continuously be in touch with, let's call it the electorate, so with citizens who have different realities, and the need to speak to them all the time. And I find that it is a bit different when we go at European level then, where the whole electoral system is totally different, and where we end up having, especially in Brussels sometimes, you know, the Brussels bubble, decision makers that are in their own bubble and barely speaking with the different sectors of society. I think that something good that is currently happening is the empowerment of citizens for them to meet the institutions. I would rather have it differently. I want the European Parliament to be present in the different cities, in the different towns, villages all across Europe. But at least for now, we have a system through which citizens can actually actively participate in European decision-making, maybe for the first time. Let's make sure that this continues, that it is strengthened, that it is made easier for them to reach out, but then let's instill in our politicians, in the next 5 years especially, that sense that, listen, before we actually legislate, before we actually make policy, we need to listen to the different categories of people that actually are affected with every single legislation that we are working on. So that is my hope for the future, not only of Europe, but of all other parliaments, decision-making bodies in the world. We need to have more people taking the seats of those decision makers who are actually impacted and affected by the policies being decided. I know I've repeated this a lot, but I'll keep on doing so.
Very quick, last comment.
Yeah, very, very quickly. I think there is a slight problem in the narrative of we should allow, and no offense to anyone, because who are we and who are them? I think the narrative is a bit misaligned on there is someone that keeps the power of allowing someone else to participate. So that narrative can only be changed by prescribing, by prescription of legislative and policy-making processes that should make sure that lived experience is part of the processes from the very beginning. So rather than having inclusion and co-creation at the mercy or the generosity of those that hold the power and make the decisions, the prescriptive process should make sure that that inclusion, that co-creation is there from the beginning. And then the narrative will change, hopefully. At least we aim for that. So there is no more we and them, but it's all us.
Thank you very much. So I want to say a huge thank you to all of our speakers, panel members, and to Joan Marsh for moderating the session. I want to especially also thank you, all of you who've come in person to attend the forum, but also the people live streaming on YouTube and on the Congress platform. I hope you've all enjoyed it. Now, before we finish, there's one person who is incredibly important in all of this, which is Professor János Réthelyi, who's the chair of the local organizing committee. In other words, the person without whom none of this would happen. So it's my pleasure to introduce him and allow him to say a few words in closing. János.
Thank you, Julian, and thanks to all of you. It was great hearing the discussion. I think this is a bit of an overstatement about my own role in this conference. When I was first approached by Hungarian colleagues and Geert, and I was told that they would like to have the EPA Congress in 2024 in Budapest, I was happy. I was somewhat happy. And then we started talking, and then Geert wrote me an email. Well, what do you think? Do you think of the motto, mental health, open and inclusive? Would that be something? Would that be a good message in Hungary today? And I said, well, I think so. I think that's a good message. And I became happier. And now, this morning, when I entered this room and I saw all of you, I'm really happy. It's so good that you've come from all different countries, and we haven't even started. So the Congress is just starting now. I would like to invite you to participate in as many sessions as possible, enjoy the upcoming sessions, participate at the opening ceremony, and enjoy your stay in Budapest, which is a beautiful city, and Hungary is a beautiful country. And I think what we heard was already so fascinating, so interesting. I'm a director of a university clinic, and what I always tell my young colleagues is, if you want to be a good psychiatrist or a good psychiatric nurse or a good clinical psychologist, you have to cope with the complexity of this field. You have to be a good doctor, a good psychologist, a good nurse. You have to know about healthcare funding. You should be a good communicator, a good teacher. You should be able to do research. It's okay if you specialize on one of those, but still keep in mind the complexity of the whole thing. And this is exactly what we've been hearing this morning. So thank you very much, and my last task is to invite you to lunch. Thank you. Goodbye. See you later.